I'm going to give two talks this morning. This one is, I was asked to talk on growth and development in patients with Smith-Lemli-Opitz, and these are topics that are close to my heart as a pediatrician who cares for children with medical complexity and as a person boarded in caring for people with developmental disabilities. So patients with Smith-Lemli-Opitz are often smaller and shorter than other pediatric patients. And there are many factors that contribute to that. So first of all, there can be different kinds of birth defects that some patients with Smith-Lemli-Opitz have that can really affect feeding and can affect how quickly you grow. So problems like heart defects or kidney function problems can absolutely affect how quickly you grow, and very often children with heart problems and kidney problems are very little for their age. And then cleft palate is a very common problem for patients with SLO, and if you have a cleft, it's often hard for those muscles to work in your mouth, and that can affect feeding. Many patients have neurologic factors that affect feeding, so having very floppy muscles, low muscle tone, we call that hypotonia, and having the muscles not coordinate and work well together can very commonly affect the ability to feed orally. And then gastrointestinal GI disease. You all heard a very wonderful talk yesterday by a gastroenterologist, but certainly GI problems can affect feeding very significantly. I'm going to talk in a little bit more detail about that in a few minutes. So intracurrent illness, getting ear infection after ear infection, getting pneumonia, just getting a stomach bug that lasts, instead of just 1 or 2 days, 3 or 4 or 5 days. All of those problems, being able to tolerate illness, are extremely common. And historically, back in the 80s and 90s, early 90s, many of my patients were just very ill, especially during early infancy, would end up being frequently hospitalized. They would be so sick. And so that also compounded and affected the ability to grow. So as a pediatrician, when you go to your doctor's office, there are 3 main growth parameters that are followed: weight, height, and head circumference, which we sometimes call OFC. And all 3 parameters are usually involved in a patient with SLO, so the weight can be very low, lower than normal for a child of that age, and the height is often quite short and below the curve, and the head circumference can be very small, and the medical name for that is microcephaly, small head. But it's not just important to look at those 3 things separately. It's important to follow them and see how proportionate the child is and how they compare to each other. So I'm very fortunate in my clinic and special care. I have 5 dietitians, and I have at least 2 with every clinic session. And so for kids to help follow their growth, there are lots of things we can do to help, and we follow weight for length. So the baby might be short, but are they too skinny for that length even? And in older children, we follow something called a body mass index, or BMI. So sometimes the child is very thin compared to their height, and we often have called that failure to thrive. And then normally, in a typically growing child, the head circumference and the length are in a similar place on the growth curves, but if you have SLO, often the head or OFC might be fairly small compared to the other growth parameters. So as you've already heard a couple of times, there are special growth curves for following kids with SLO, and it's important to follow always kids with certain diagnoses on the diagnosis specific growth curve, so you don't get too worried if a child is not growing compared to a typical growth curve. And so in this case, the dotted lines represent typical children's growth, and the lines that are solid are kids with SLO. And so you can see this is a weight curve, and the top line is the 95th percentile, the middle line is the 50th or the average percentile, and the bottom line is the second percentile. And you can see that all of the growth, all of the weight is below the typical curve. Here is for older children. So you are not quite so low as when you're a baby and a small child. Here's the height for smaller children, and so you can see the average height. That middle blue line is well below the average height. Typically growing children, and here's for older kids too, you can see that the height is what would be considered less than the second percentile. And here is the BMI curve. So is the weight appropriate for height for kids with SLO? And here's head circumference. So you can see that that is well below the typically growing kid. So I wanted to spend a minute or two talking about GI problems, and it turned out that there are quite a few of these that can impact a child's growth if you have Smith-Lemli-Opitz. So having reflux is a very, very common thing in pediatrics in general, and if you have SLO, it's really quite common in my experience. So these are kids who have quite a bit of vomiting. And they often can be irritable in relation to feed, so they'll eat something and then they'll feel this heartburn feeling that can make them quite uncomfortable. So reflux is common. Having the intestines work pretty slowly, we call that dysmotility, is a very common thing. So some kids just have horrible issues with constipation, which can be quite severe, and if you're all full up to your eyeballs with poop, you don't have a whole lot of hunger. It can be uncomfortable as well, and it can contribute to slow weight gain. If you think of parts of the body where there are lots of cells that are turning over rapidly, the GI tract is one of those places. And because, especially for people with very low cholesterol levels, you might not have enough cholesterol in the body to be able to make new cells in a timely way. And I think that may be part of the GI issues. So the inability to absorb nutrients is also really common. You've heard yesterday that you need cholesterol to do lots of things, and one of the things you need cholesterol for is to make bile acids, and bile acids live in your intestine, and they are necessary to absorb nutrients and things like fat-soluble vitamins in your gut. And so many of my patients whose cholesterols are very low can't make enough bile acids, and then their intestine is just not able to absorb nutrients very well. And then the other thing that you may not have heard before, but in my practice I've seen quite often, is significant food allergies. When we were trying to figure out how to get cholesterol into my patients, we would run into the stumbling block of, oh, I can't feed my child eggs because they're allergic to eggs. And eggs is the food that most people think about to try to get cholesterol into their kid. So many of my patients were allergic to eggs and also allergic to meat and milk and some of the high cholesterol foods that you would think about, and that made it really, really common. So if you are a person that has multiple food allergies, you can develop a condition called eosinophilic esophagitis, EOE for short. They didn't even know about EOE back when I was in medical school or in my pediatrics training. It's a condition that I really learned about in the past 10 to 15 years because there's an expert in EOE at my hospital in Colorado. But it's inflammation inside related to eating something you're allergic to. So most of us are familiar with getting hives if you're allergic to something, but that kind of swelling and inflammation can happen inside throughout your whole GI tract. And if you haven't figured out what you're allergic to and take those foods out of your diet, that inflammation just gets worse and worse and worse and can cause symptoms that look like really, really bad reflux, but the treatment for EOE is different than just reflux medicines. And so to figure that out and to find a good GI doctor who knows about that can be really important. So because of all of these different problems that can contribute to feeding issues and slow growth, very often the question comes up, what is best to feed your child? Do they have to be on a strict elimination diet because of multiple food allergies? Or if they're on a formula because they're G-tube fed, what are the best formulas? What has the most cholesterol in it? So for infants particularly, I think for all infants, no matter what you got, breast is best. That's my pediatrician mouth talking. But breast is really good for children with SLO because breast milk has more cholesterol in it than any other formula. So many of my patients have been really amazing and have pumped for a very long time to be able to feed their child breast milk. There are many, many other formulas that are available to feed children who have feeding issues and growth problems. And I actually had a couple of my wonderful dietitians in my clinic do some research for me for this talk. And they called up all of the main companies that make formulas for children. And the very, very sad thing is that none of the high-calorie formulas or regular infant formulas contain cholesterol to any sufficient degree. None of them do. So there are formulas that are broken down, elemental formulas that I use quite a bit because the gut is sick. There are formulas that are non-dairy, non-soy. There's formulas based on pea protein. There are formulas that have lots more calories in them than traditional milk. So milk and baby formula are 20 calories per ounce. Often I use formula that's 30 calories per ounce, like Pediasure or Boost Kids Essentials or Nutrin. Those are all 30-calorie formulas. And then there are formulas that are 45-calorie formulas, 1.5 formulas, and then there are 2.0 formulas for older kids. So there are lots and lots of choices now, more than I ever had before. But still, none of these formulas contain cholesterol. None of them. For older kids, need more calories than babies do. So typically, by the time you get to be closer to, mid-teens or up to over 20 pounds, you can switch to a 30-cal formula, and then we can add things to those formulas that bump up the calories. We can have concentrated formulas if your child can't take a lot of fluid restriction. The problem with these special formulas is that insurance, private insurance like Anthem or United or all of these things, they don't pay for these. So if you have to pay out of pocket, it's really expensive for these formulas. Medicaid does pay for them, so I often encourage my families to get Medicaid as a secondary insurance so that the formula can be delivered to your house and you don't have to pay out of pocket. Instant breakfast is a really good option for people whose insurance won't pay for expensive formulas. If you add a packet of instant breakfast to a glass of whole milk, that's the equivalent of a Pediasure. There are special formulas that look like juice instead of milk for those kids who don't want to drink milk, and then they're all different flavors. There's chocolate, strawberry, and some of the higher cal formulas that give you the same nutrient value as, say, a Pediasure, but taste like juice. They have vitamins and correct balance of protein, carbs, and fats, so they can nourish your child very well. So I'm going to just blast through this slide in terms of feeding tubes because you heard such a really good talk about that. Yesterday, I just wanted to mention in the slide, how do we figure this out if a child is aspirating? The study is called a modified barium swallow. It's a special x-ray study to see if food is going down into the lungs instead of the stomach, and there are different kinds of thickeners that we can use so that kids who aspirate thin liquids or certain textures can have their formula thickened and be able to take them more safely. And then the really important thing that I just wanted to mention is the difference between a G tube that goes into the stomach and a J tube that goes into the intestine. Your stomach is a big container, and you can use bolus feeds and give a kid 8 ounces all at once. But a J tube, you have to drip it in slowly, and that means that your kid is hooked up to a feeding pump sometimes for many hours during the course of the day, and it can really affect the quality of life and how much you have to be hooked up to a tube. So it's a big decision to think about a J. So I'm going to come down on my side of the fence about cholesterol supplementation and say this based on my experience of the past 25 years of caring for kids with Smith-Lemli-Opitz. So I remember very well what it was like for my patients before I could give them cholesterol, and I have experienced that may be a little bit different from some of the experts that you've heard already, in that many of my patients tend to fall in the more severe end of the spectrum. And so their cholesterol levels may be 8 or 10 or 15 or 20 or less than 40, less than 50. And if your cholesterol is that low, it's hard for there to be enough cholesterol to meet the needs of the body. We talked about bile acids. We talked about the importance of cholesterol in all the membranes of your body. So you need cholesterol for your skin cells to be healthy, your GI tract to be healthy, your retinal cells in the back of your eye to be healthy. And your liver, where cholesterol is made in your body, will work very, very hard and over time to try to make cholesterol, but only succeed in making precursors instead if you have more severe disease. And many of my patients had liver problems too, and really elevated liver enzymes. And what we know now, 25 years later, is that it's not just the low cholesterol that's the problem, but it's the accumulation of the precursors, the 7-dehydrocholesterol and its isomer 8-dehydrocholesterol. And those precursors undergo a chemical reaction. They get oxidized, and they are turned into very, very toxic substances called oxysterols, which can be harmful to your brain, your eye, your skin, your liver, everywhere. And so part of my feeling that cholesterol is important is that I'm using it not just to raise the cholesterol, but to also turn down the production of precursors, to try to decrease the number of toxic substances that are accumulated. So there are lots of ways to do this now, many more ways available than there used to be back in the 90s when I first started this. You can go online and buy cholesterol flakes, cholesterol powder. In the past, some of my colleagues developed an aqueous cholesterol solution. That's a solution that is compatible with water. The suspension that I created back in, have been using since 1994, is a suspension that takes pure pharmaceutical-grade cholesterol and mixes it with soy oil. This is done by a compounding pharmacist. And it's the equivalent of 200 milligrams per ml. 200 milligrams is about the amount of cholesterol in one egg yolk. So with a teaspoon, 5 mLs of my medicine, I can get the equivalent of 5 eggs in very easily. When I practiced in Boston for 17 years, I had a compounding pharmacy there that made this and shipped it out. And then since I moved to Colorado now 18 years ago, I found a pharmacy in Colorado that's a compounding pharmacy, so they make up this medicine and they ship it out to families all over the country. And it's a way that I figured out to get cholesterol in, especially to patients who are fed through G-tubes. And as I mentioned, none of the formulas have cholesterol in them. And so this way I can get cholesterol in, and even in those patients who are egg allergic, I can do it. So I just wanted to mention for a second about other nutritional deficiencies. So 3 main things that I measure and follow quite closely in my patients are iron, D, vitamin D, and zinc. So iron you get mostly from meat, and a lot of people can't eat meat. If your iron is super low, your sleep really stinks. So I do a lot of iron medicines in my patients, and my pharmacist helped me find one that actually tastes good and doesn't give you the worst constipation in the world, which has been the problem with older iron stores. So the perfect level of the iron test is called ferritin. The perfect level is 50. Some of my patients have ferritins of 5 or 10 or 12. And if your ferritin is that low, your sleep will be awful. And like magic, I can fix that. You can't give iron with dairy because it interferes with absorption, but vitamin C helps with absorption. So I always explain that to my families. Low vitamin D is very important for healthy bones and normal calcium, and vitamin D supplementation is simple. It comes in many forms. I'm actually giving a lot of vitamin D in the antioxidants I'll be talking about later. And so getting normal vitamin D levels in my patients has been pretty simple. Zinc is interesting. Zinc comes in the same foods that give you iron. So many of my patients are deficient in both iron and zinc. The symptoms of zinc deficiency are really, really bad appetite and often rashes that look like eczema, bad eczema. And so I measure zinc levels and often supplement with zinc, and that helps the appetite be better and the skin problem be better too. So to summarize the growth phase of this talk, there are many, many issues that can impact growth and adequate nutrition in patients with Smith-Lemli-Opitz. Patients are often small and short to begin with, so you have to have appropriate expectations for what a normal growth should be, but there are also feeding issues that often require the assistance of dietitians and GI specialists, and special formulas can be helpful. Some of my patients, but not all, have required feeding tubes. If your child has multiple food allergies, it would be good to talk to your pediatrician and see a GI doctor who is knowledgeable about eosinophilic esophagitis. And striving for weight that's appropriate for the patient's height is a very important step, using the right growth curves, and then optimizing all areas of nutrition. And looking at all the other things that you can fix. There's a lot. I'm a geneticist, and I take care of very complicated patients, and I cannot cure my patients for the most part, but I can help them, and that's what I'm striving to do. Questions about the GI part before I move to the developmental part. Can you please come to the microphone to ask your question?
Cholesterol supplements. We live in California, we have Kaiser, and we've asked multiple times to get cholesterol supplements because it's a hard time getting egg yolks in my daughter. It's a fight. So can you advise on how we can get a hold of something like this if they repeatedly say our pharmacy doesn't have this, we don't have a vendor for it?
Right. That's a good question, and it's not an easy answer. I wish it was. So I've dealt with lots of insurance companies, and the compounding pharmacy that I use will work really hard to try to get different insurance companies to pay for the cholesterol, the compounded cholesterol. But for many, many of my families, they just have to go online and pay out of pocket for the different kinds of cholesterol flakes or powders and so on. If your child doesn't have food allergies that are restricting her, then you have to be a little bit more creative if you're doing it with food. And so some of my families have invented incredible milkshakes and other cholesterol-high substances. There is an SLO food, a recipe book that actually came out of the folks in Portland, Oregon. And my dietitians have it, and I'm happy to copy it and send it via email to people. And it gives you good ideas for making recipes of cholesterol-high foods. I don't know if there's anybody still in Portland who is a contact for getting more of those, but I know we have copies, and we can just make copies and send it out via email to you to get some good recipes for those of you who are eating. What? You might have to try that one.
Fun. Oh, there we go. I have a question from one of the families asked us about EAT bars, the bars for dysphagia, and products like that make swallowing a little bit easier. So, of course, I got interested and I thought, oh, perfect, I'll call for some samples. And, of course, I have them in my hand. And I'll let everybody have one. They're for kids that have trouble swallowing. What kinds of products do you have to help growth and development and get calories in your kids like this? Do you have a list that you let people know about, and could we know about your list? And what do you think about things?
So I work closely with very talented dietitians, and they have lots of different kinds of lists, foods that are rich in iron, foods that are rich in other things, depending on what the particular problem might be. Many of my patients are followed by feeding therapists, and feeding therapists can be very helpful in terms of the texture problems. So feeding therapists can be occupational therapists, or sometimes they're speech therapists too. And if you live in a place that has a big pediatric hospital, many pediatric hospitals have a feeding team. And I often work with those teams to assess the child, see what the specific feeding problem might be, and then try to figure out what would work best for that. I mean, the bottom line is that one size does not fit all, because feeding problems are complicated and are different for each patient.
What type of testing do I need to ask my pediatrician for the vitamin D, the iron, and the zinc?
So the iron test is called ferritin, Ferritin. The form of vitamin D we check for is 25-hydroxy vitamin D. And hydroxy is OH, so 25-OH vitamin D. And then the zinc is just a serum zinc. And there are standardized normals for those tests that your pediatrician will be able to interpret. The one caveat to that is that depending on the lab, it might tell you a ferritin of 20 is normal. That's not true. The optimal ferritin level is 50, and that's the level I try to get close to. All right, I'd like to move on and talk about developmental stuff to keep on time here. So In wearing my developmental hat, I wanted to spend a few minutes talking about the spectrum of developmental disabilities in patients with SLO. It's a pretty broad spectrum, and there are patients, in fact, with SLO who fall in the normal range of intelligence that's been reported. But for the vast majority of patients, they fall in a range of disability from mild to extremely severe. So as a developmental pediatrician, I divide development up into different areas, and there are four main ones. One is gross motor, that's things like rolling, sitting, standing, walking, running, that kind of stuff. What you do with your whole body, that's gross motor. Gross motor skills are very dependent on muscle tone, so if your muscle tone is floppy, you're going to have gross motor delays. And gross motor problems are the least best predictor of future intelligence. So I can have a kid who's walking at the normal time but still have severe intellectual disabilities because it's a different part of the brain that helps your body move. Fine motor skills are the things you do with your hands. So being able to get dressed, being able to feed yourself, being able to do snaps and buttons and zippers, and then when you're older, being able to write your name, write letters, things like that. Those are fine motor skills. And often if your body is very floppy and your core is really weak, it's very hard for the end of that crane to be able to do fine motor tasks. So fine motor skills can be affected by severe gross motor delays, or they can be a separate problem in and of themselves. Language to me is a very important area to follow because the language that children develop is the best predictor of how intelligent you will be later. I think of language in two ways. What do you understand of what is being said to you? That's receptive language. And what can you communicate? And that might be sounds you're making, words you can say, or sign language that you can use. And then there are social and adaptive skills, things like playing and being interactive, becoming toilet trained, figuring out how old you are, if you're a boy or a girl, and how well you interact with other people. These skills can be affected, particularly in people who have autism. So if you have the combination of low muscle tone, some people have brain defects. If you have SLO fairly severely, all four of your areas might be impacted, and we call that global delay. But for some people who have more mild issues, these areas can be impacted to a more mild degree. So if you have motor problems, physical therapy is the kind of intervention we recommend to help people be able to do things with their whole bodies. Occupational therapy is what we recommend for fine motor issues. And language development, as I mentioned, is one of the most important things I look for, and a speech and language pathologist can be very helpful. It's extremely important to document what the hearing status is, because hearing can very frequently be impaired. I'll talk about that in my subsequent talk, and if your hearing is terrible, then your language development can be impacted. And then Dr. Tierney is here, and she is really the world's expert in terms of patients with SLO who also have autism. It's a fairly common association, and if you have autism, then your ability to communicate and also your behavior and your social skills are impaired. There are special interventions for children with autism and classrooms that can be particularly helpful with teachers who have special training, and then behavioral interventions, particularly ABA, can be extremely helpful for those patients. So how do we sort of assess how severe or problematic the developmental delay might be? So in small children and infants, we look at something called a developmental quotient, and that's a fraction where we take what age a child is performing at divided by their actual age and multiply by 100, and that gives you your developmental quotient. So for example, a 2-year-old child who is acting most like a 6-month-old will have a developmental quotient of about 25%. And we do the same thing with a different kind of test. In an older child and an adult, we look at what level you're functioning at, divided by your chronologic age, and multiply by 100. So a 10-year-old kid who is functioning most like a 4-year-old would have an IQ of around 40. And this is just a bell-shaped curve to show you what we sort of think about in terms of what is normal intelligence. So a normal intelligence is an IQ in the range of something like 90 to 110 range, and if your IQ is above that, so you're a 10-year-old who's reading at a high school level and is reading Shakespeare and physics and so on, your IQ is way up there. If your IQ is in a sort of 80 to 90 range, that's a low average, and 70 to 80 is kind of borderline. And then anything less than 70 is what we define as intellectual disability, but within that, there are ranges. So you can just be a mildly delayed compared to your normal peers, and that might be an IQ in the 55-ish to 70 range, and then a moderate intellectual disability would be more like in the 40 to 55 range, and if your IQ is in the 20 to 40 range, we call that more severe. And if you never learn beyond infancy, and you don't develop any language skills or other communicative skills or interactive skills, we would call that profound. And I have some patients who function in that area. But most of my patients fall. I tend to see more severely involved patients in the moderate to severe range, but many, many, many patients with SLO function in the more mild range. So this fraction doesn't go on forever, right? If you're 50, you're not going to be acting like a normal 25-year-old. So does anybody know what age does your brain get its best sort of ability to think abstractly? Anybody want to guess? Mid-teenage years is, so that's why, whoops, I lost this. You go to high school and you can take physics and algebra and read philosophy and Shakespeare, but you can't do that in first grade, right? You're not able to think abstractly yet when you're much younger. So the age when your intelligence develops to that level is about your thank you. I didn't get it on well. Here we go. And then I have my glasses in the way too. Here we go. So, so when I'm explaining this to families and trying to give them a sense of, okay, my kid is only 2 now, but what will they be like when they're 20 or 16 or whatever? If you have mild delays, you might be functioning like 2/3 of around 15 or 16, okay? Moderate delays, about half of that as your final level of functioning when you're, I'm just giving you ballparks, right? People with severe intellectual disability sort of they develop skills maybe like a preschool age kid, and then people with profound disabilities are like infants their whole lives. And so it just helps to give you an idea of kind of what you might be able to expect. And we can follow developmental curves for patients like I'm following weight, height, and head circumference, because unless something happens to you, like you get terrible infections or have some bad accident or bad illness or something like that, your developmental function tends to be fairly constant. It can be followed on a growth curve. So we just talked about this, but do you stop learning ever? Of course not. You never stop learning. You can be 110 and still be learning new things. So that's an important distinction. How you can learn and how abstractly you can understand things is very different from stopping learning completely, right? If you stopped learning, why would you ever go to college or med school or get a PhD or read a book or read the newspaper or have a thoughtful conversation with somebody? You never ever stop learning. And that's what I hope for my patients, is that I get them services so that they can continue learning to their true potential, whatever that might be. So I already talked about these things and how to predict. So let's talk for a minute about the kinds of educational services people can have. So from all over the country, no matter where you live, from birth to age 3, you're entitled to early intervention services. And these are therapists and developmental specialists come out to your home, so they're generally home-based services. And which program you are assigned to is determined by your zip code and your address. Insurance is not routinely charged for these services. You're not going to hear from your anthem, oh, you can have 8 sessions of PT and you're done. These you can have from birth to 3, and you don't pay for these services. When you're 3 until age 21, you can get these services through school. You have the development of a plan called an Individualized Education Plan, or an IEP. And that is very much individualized depending on what the kid's needs are. Does your kid need G-tube feeds in school? Does your kid need PT, OT, speech? All of these things can be built into the plan. And to meet the medical needs, there's often something called a 504 that'll help with feedings and diaper changes and things like that. And then behavioral supports can also be very, very important, both at school and at home as well. You heard a lot yesterday from that attorney about what happens legally for people. I've talked to people here who have had the pain and torture of going through the guardianship process. You have to do it. And it can be very expensive and painful, but it's a have to when your child is 18, but at the time your child is 18. And then what kinds of programs your child is eligible for after they're 21 and they graduate from school are very variable depending on where you live. Communities have programs called CCBs, Community Center Boards, and they can be very, very helpful to get you services and to help pay for alterations to your home and to help find appropriate things that you might need to help your adult-age child. So your CCB is really your anchor and your lifeline when you have an older child. In my state, in Colorado, there are very, very long waiting lists for a lot of these programs, and my very smart families start looking in late teens so that things are set up by the time they need them. So that was a quick romp through the developmental aspects of having SLO, and I'm going to stop there and take questions. No questions. We've got that developmental stuff. Well, there's a question. Good.
The CCBs that you mentioned, I mean, we're planners, so do you know of any certain states that have better programs than others? I know you said Colorado, there's long waiting lists. Do you know of any others?
But we have good CCBs and good programs that are, depending on where you live. And so, I always ask families, so where do you live? Oh, fantastic.
Because we are open to moving,
Yeah.
When she's an adult, we'll go where the services are. So.
Right. It's
Okay.
No, 21.
22 in California, I think.
Okay. Yeah. So that's amazing. Moved to Michigan. No, I was in Massachusetts for a long time, and Massachusetts was terrific too. but it's very individually dependent. You know, you might have some fabulous person at that community service board who is, you know, the best thing that ever happened to you. So I can't tell you move. It's really.
I've heard of good things, Phoenix, Arizona, too.
Yeah,
So
yeah.
just, you know,
It's a journey. It's a journey. Well, thank you very much for your attention.